اللبس أعاني صعوبة يعني جدا جدا، بس يعني ما شاء الله لو جيت أقارن بالفوائد الجهاز الذاكري جدا جدا يعني عظيمة. هو يعني ما أدري إذا كان حديث أو قديم، بس إنه يعني معجزة طبية، يعني ساهم في تثقيل الجرح، ساهم في تقليل المضاعفات، يعني جدا جدا جهاز ممتاز. كنت أعاني أنا بما إني أم، كنت أفكر في يعني أولادي أكثر من نفسي. لما كنت في المستشفى يعني تقريبا قرابة 4 شهور ونص في التنويم، فكنت أقسم وقتي بين المستشفى وبين أولادي يعني. فكان جدا جدا صعب يعني كوني أم، يعني ما كنت أفكر في نفسي، كنت أفكر فيهم. الله فريق الطب حق كير يونت كان جدا جدا يعني محترف، وبدون ذكر أسماء يعني ما شاء الله عليهم، أفخر فيهم وأعتز فيهم جدا، وكلمة شكر قليلة عليهم. فريق الطب جدا جدا متعاون وجدا يعني بصدر رحب وبتفاني وبتعاون منهم قدرت أتخطى المرحلة الصعبة جدا جدا. فريق الطب اللي هو فريق الجراحة العامة، فريق جراحة التجميل، فريق اللي هو عناية بالجروح، يعني لهذا اليوم هم مو مقصرين ومتفانين في العمل ومخلصين جدا، ومرتاحة معهم كثير يعني. الله يعطيهم الصحة والعافية. الحمد لله أنا يعني فترة تعافي، فهذا فضل من الله سبحانه وتعالى.
This is a small appreciation from the nursing department and the hospital administration to the wound care team. Thank you so much. معنا نسأل الشركات الراعية لهذا الورك شوب.
شركة مملكي أستاذ فيصل، شكرا لك. تفضل. We would like to thank عبر العربية أستاذ براء. تفضل. with care. شركة سميث ونيفيو أستاذ علي. We'd like to thank you, everyone. We will start our opening with Dr. Sousa. Dr. Sousa, she's a plastic consultant in our hospital, Kirkland Hospital. Welcome to Sousa.
Assalamualaikum. Good morning, everyone. Sousa Nidou, Professor and Plastic Consultant in Shahid Hospital University. When first Ms. Malak assigned me to this topic, what every doctor should know, it's a wide topic, and obviously I cannot cover it in a session. So I'm going to highlight the important points, and hopefully over the course of 2 days, we will go through these points in details. So the important points in there covered is how to perform a comprehensive wound assessment. And you should be able to understand the stages and the complex process of wound healing, management strategy, and addressing the underlying causes. You should be able to do proper documentation, and you should be up to speed with the advancements in wound therapy and to avoid common pitfalls. This all to achieve a proper wound care. So the goal of comprehensive wound assessment is to be able to categorize a new wound according to their acuity, whether they're acute or chronic, based on their depth and based on the contamination. This will help you to formulate a management strategy that's personalized and suitable for your wound. And the wound assessment, basically you do history and physical examination, you cover the patient's comorbidities that affect wound healing, medication that hinder the wound healing, such as steroid, identify whether the patients have allergies or not, wound history itself, the cause, duration, previous treatments, and its outcome. Lifestyle factors that affect wound healing, such as smoking, dietary habits, and adherence to treatment. Then the physical examination, basically the vital signs and perfusion status that will help you to decide whether the patient is septic or not, or to predict the prognosis of the wound based on their perfusion status. Then the wound assessment in terms of location, size, edges, and exudate and surrounding skin. You also have to be able to assess for infection based on local sign, the classic local sign of redness, hotness, and tenderness, and sometimes subtle signs such as delayed wound healing, fiber granulation tissue, and increase in exudate production. Systemic sign will tell you that the patient is going into sepsis, such as fever, chills. Then you have to do diagnostic, such as swabs for cultural sensitivity, and you might need to do blood work in form of CBC, WBC, ESR, CRP, and sometimes you need imaging to rule out deeper collection or osteomyelitis. Part of your examination should be evaluation for vascular and neurological status to rule out arterial and venous insufficiency, and also to rule out neuropathy. Pain assessment is important to help you decide whether the patient is candidate for bedside debridement or not. Finally, you have to document your finding, whether in brief note or by photography. It helps a lot in monitoring the patient and monitoring their progression. But you have to be consistent in terms of lighting and ambient. Special consideration in patients with pressure ulcer, you should use the National or European Panel Advisory for Pressure Ulcer Classification. Diabetic foot patient, you should consider offloading the foot and refer the patient to diabetic foot specialist to evaluate for sharp joint. And for surgical wound, you assess for dehiscence, hematoma, fistula. In case any of these are present, you have to refer the patient back to their primary surgeon. Not to forget the holistic factor of the patient, their nutritional status, psychosocial, and surrounding environment, whether they have the social support or not. It's a dynamic process that requires reassessment, frequent reassessment every 1 to 2 weeks, or sooner if the patient is deteriorating. You should be aware of the red flags, such as delayed no improvement within 2 to 4 weeks, or any sign of osteomyelitis, gangrene, or malignancy. It's a multidisciplinary approach. You should involve the wound care specialist, vascular, plastic surgeon, and infectious disease specialist. Second part is to be able to understand the complex process of wound healing. It's a dynamic process of 4 phases that might overlap. Start with the hemostasis phase, which lasts within seconds to minutes from the injury. It's characterized by platelet aggregation and vasoconstriction. The aim of this phase is to form a big plug that will stop the bleeding. Followed by the inflammatory phase, which starts from day 1 to day 5, characterized by vasodilation, aggregation, fibroblast infiltration, neutrophil infiltration, granulation tissue formation. Followed by the proliferative phase, which starts from day 5 plus up to day 21. The main cell in this phase is the fibroblast, which will lay down the collagen, granulation tissue, and angiogenesis. Last phase is the modeling phase, which can last up to 8 months post-injury. In this phase, it's basically rearrangement of the collagen fiber and conversion of collagen fiber from type 3 to type 1, which is more durable. Management strategy, basically you have to answer first question is whether the patient needs debridement or not, and what type of debridement you're going to do, automatic, enzymatics, or surgical. Once you decide on the debridement, you have to decide the type of dressing you're going to use. It's mainly rely on the amount of exudate you have and whether the wound is infected or not. If you have a light exudate, then hydrocolloid is your best choice. If you have a heavy exudate, then alginate or foams is the best dressing. Obviously, there are many types of dressing, but this is the main category. And it's infected wound, then you have to consider including antimicrobials such as silver, nanosilvers, and antibiotic invaginated dressing. Try to avoid cytotoxic agents such as hydrogen peroxide and outdated protocols such as wet-to-dry dressing. Also, be aware of the infections. Sometimes patients will require systemic antibiotics to control the infection, or local antibiotics. Your management strategy should address the underlying cause and should be patient-centered. The underlying causes, such as diabetes and immunocompromising conditions, should be under control. If the patient have any diabetic foot or partial ulcer, you should consider offloading these areas. Also, you should educate your patient on hygiene, protocol of dressing changes, optimize their nutritional status, and involve other specialty that will help in managing the patient. Monitoring and documentation is an important part of wound care. It will show you the progress of the patient and whether the patient is going up or down. Reassessment is done, as we said, from every 1 to 2 weeks or sooner if no improvement. Advancement in wound care, there are many advancements. The driving factor in advancement in wound care is finding a suitable dressing that is cost-effective and control infection. These are some of the new dressing products, such as the smart responsive dressing. These dressings are embedded with a sensor that will monitor the pH, moisture, and temperature wirelessly, and it will give you an alert when the patients need to change the dressing. The bioactive dressing is dressing that is embedded with growth factors and stem cells, which will help in wound healing. Hydrogen and hydrocolloid upgrades. Nowadays we have a hydrogen dressing that is infused with oxygen particles, ions that will increase bone dressing is becoming more absorbent and impregnated with silver nanofibers and negative pressure therapy has been there for a while, but now it's becoming multiple devices with single-use devices, so you don't have to worry about the device. And finally, the multi-material dressing, where you have more than one technology in one dressing. So you have to be up to date, choose the suitable dressing for your patients, and think about the cost effectiveness and the availability of these dressings. Problem that falls to overlook the psychosocial aspects of women's care. Basic mental health and social support is important. Training to address typhoid, gangrene, or possibility of malignancy is a common pitfall in women's care. Final step, stay up to date with the evidence-based women's care protocol, and individualize your care, prioritize the best parts of wound management. Regularly assessment and adaptability is a key factor in wound care.
Thank you, Dr. Sosa, for informative lecture. Please welcome with me Mr. Ali Ibrahim. He's a Master of Nursing Administration and has Master of Wound Care. And he's also a leader of Knowledge Project for Patient Prevention. And he's also a member of European Wound Care. Welcome, Mr. Ali Ibrahim. He came from Jazan, so big clap.